So endophthalmitis doesn't necessarily mean that you are at fault, and it can be very devastating to the surgeon and to the institute where you're working at. It can draw you into a legal battle, or you can be a part of a panel discussion, which definitely is not something any one of us looks forward to. As I said, it does not necessarily mean that it is evidence of substandard care. It can happen to anyone, and the typical presentation that we have of a post-operative bacterial endophthalmitis is something like this. But this is not always so easy to recognize and diagnose. So first, some pitfalls that we can have for diagnosis. This is a patient. You can see there's a trace hypopion. There's a slight area of injury that the patient gave a history of with a barbed wire. And we thought that this is endophthalmitis that we are looking at. But if you see the ultrasound, the vitreous cavity is really clear, conservative management, and the patient did very well. This, in contrast, is another case, very few signs in the anterior segment, just a few cheretic precipitates, few membranous exudates in the vitreous cavity, and this is a patient who had undergone vitrectomy for retinal detachment surgery. And typically on OCT, media was so clear that we could do an OCT, and these pre-retinal hyperreflective spots was all that was seen. AC tab did not reveal any organism, so conservative treatment was started for this patient. Patient came 5 days later with a drop in vision. Vision is only PLPR. We took up for surgery, removed oil, and the retina was so very much necrotic. The silicone oil itself showed the presence of Mycobacterium chelonie, and we had to put the patient in. This is one of the rapid growers Mycobacterium that are known, and we had to start the patient on multiple therapy for the same according to the antibiotic sensitivity. Again, another entity which you need to differentiate when you are thinking of a post-operative endophthalmitis is TAS. So whatever, once the diagnosis has been done, the first line of management is in form of intravitreal antibiotics, and the most common combination is that of a vancomycin combination of intravitreal drugs, because almost 80 to 90% organism will be susceptible to these agents. But what happens when there is an inadequate response to the intravitreal drugs? What do you do then? So this is where the EVS study gave us the guidelines for surgical intervention, and traditionally we were taught that for cases of only PL plus is what we need to take up, worse than PL plus is what we need to take up for surgery. But, and this kind of surgery which was a standard 3-port vitrectomy, and they recommended that only about 50% of the vitreous needs to be removed. No PVD induction is required, and surface of retina should not be touched to remove all those exudates that you may see. Even intraocular lens was removed only in select number of cases. But such kind of a surgery can leave behind a lot of purulent material in the posterior vitreous, and eyeball is almost like an abscess, and presence of this purulent material can cause even a hypopion on the, or a posterior hypopion, which we call on the macula. So that's why I said it's like an abscess, and whenever you think of an abscess, the first thing that you want to do is drain the abscess. So now what has changed is that we are all looking at a more radical vitrectomy, more complete removal of the vitreous, complete PVD induction, and with MIVS, our iatrogenic problems have become much lesser, so the risk of retinal detachment is less. Wide-angle viewing systems allow us to see the periphery also well, so we can clean up the vitreous cavity much better. Vis-a-vis EVS time, when nearly 100% of gram-positive organisms were susceptible to vancomycin and nearly 90% were susceptible to ceftazidime, that is not the case now, with the ceftazidime sensitivity reducing to less than 50%. So surgery is important because it gives you the identification of the organism, and you can do a targeted treatment with antibiotics. So it does give you a lot of advantages, that increased nutrition gives you organism identification, but there can be some issues as well, because you may have the media which is not so clear, the cornea may not be clear very early on, and you may end up causing more issues. So keeping this thing in mind, keeping the EVS criteria in mind, as well as the newer information that we have, keeping that in mind, I would say that these are the few things where I would directly go in for the surgery. The EVS criteria, of course, and the second, if there is no view on indirect ophthalmoscopy and the progression of disease is seen even 24 hours after the intravitreal injection, patient is a diabetic, which is not under control, or a virulent organism, and in cases of chronic or delayed endophthalmitis, you would want to take up the patient for surgery directly. Special situations like fungal endophthalmitis, traumatic endophthalmitis, endogenous endophthalmitis, endophthalmitis after retinal detachment, and with retinal abscess, EVS did not give us any guidelines. I'll just discuss a few cases to represent these scenarios. So this is a case of post-traumatic endophthalmitis with intraocular foreign body. Nobody will wait for anything. You have to take up the patient as an emergency, remove the intraocular foreign body, and take care of the endophthalmitis. Even today, infection with bacillus is one of the most common causes of patient needing evisceration. Some of these cases of traumatic endophthalmitis may not immediately present with endophthalmitis. Here is a case example where there was a foreign body which was removed, patient underwent vitrectomy, there was no infection at the time of surgery. But the first post-op day, this is what the patient looked like. So this is an exaggerated response or presence of some kind of infection which was there during the injury itself, and it has all come up front into the AC now because the oil is there in the vitreous cavity, which does not allow the growth of organisms. So here, conservative treatment with steroids and IV antibiotics did the trick, and the patient has resolved infection. Another example, we had a patient who was not responding to conservative treatment. We took up for surgery, and I realized there was presence of this bunch of eyelashes inside, which was not picked up on any ultrasound or imaging technique. And this was what was causing a recalcitrant infection. Fungus endophthalmitis, you have to deload the infection. Sometimes even people recommend removal of the iris or the lens where the fungus can be very difficult to find access to with antifungal agents. Another one, corneal involvement. Evisceration in presence of corneal involvement can happen, the need for that can happen very quickly. So this has to be dealt with also on an emergency basis, and sometimes you may need to do penetrating keratoplasty along with vitrectomy and removal of all the infection. Retinal abscess, this was a patient of mine who just came with poor vision, and the blood sugars was something like 500, had a cataract, and underlying there was a large retinal abscess. So the surgery was imperative. We had to do surgical intervention. Another one, you can see a large retinal abscess. So surgery not only gives you access to the vitreous, but also to the subretinal space. You may have to drain it. And this is another patient where we drained it, and the subretinal aspirate had shown fungus and was treated accordingly. Another example of a patient who came to us with a drop in vision, vitreous cavity showed some exudate and this large retinal mass in the periphery, along with the scleral nodule. So Dr. Vaishali just mentioned that tuberculosis is one of the things which causes scleral nodule as well as a choroidal tuberculoma. So patient just had to be treated with ATT, and you can see the patient is responding. The abscess is receding slowly. Neonatal endophthalmitis does not follow any of the criteria followed by the EVS guidelines. This is a 1-month-old child who was sent to us for ROP screening, and we saw that the cornea was very hazy and it was bilateral. There was no clear view. We injected intravitreal immediately, but did not show any response. Was taken up for bilateral surgery here in form of lens and vitrectomy, more for endophthalmitis than for ROP. And here, when I opened up the eye, I saw that there was vitreous exudates which was flowing out from the optic nerve. The patient had meningitis and septicemia, which was not picked up early on while the stay in an ICU. So the surgery gave us a systemic diagnosis as well. 6-day-old patient coming with endophthalmitis, and you can see the number of vitreous cavity echoes which are present here. Response simply to intravitreal injection, no need for surgery. Because these children are not exposed to any antibiotics before, they respond very well to antibiotic injection. Another patient who did very well with antibiotic injections alone. This is another one who came to us with very bad corneal involvement, but here also evisceration was not done right away, and antibiotic, systemic as well as intravitreal, we were able to achieve phthisis. Important things to remember about neonatal endophthalmitis is the mainstay of treatment is form of antibiotics and systemic treatment, and not necessarily surgery. And every effort has to be made even to preserve an NPL eye, because that is important for the future growth of the face and everything for the child. So endogenous endophthalmitis was also not discussed by the EVS, so just showing you a few examples. Here, this is by Pseudomonas lutea, and this responded very well to systemic treatment, no need for surgical intervention, and patient was great with intravitreal injection and systemic treatment. Another case of nocardia infection, again, role of systemic antibiotics is undisputable where endogenous endophthalmitis is concerned. People even recommend it for post-operative endophthalmitis. Silicone oil is used not only when there is retinal detachment, but people have used it even in the presence of no RD just to contain the infection. You can do it because it's an inert medium, it does not allow the growth of organism, but things to remember is that the remaining pathogens, they can really multiply in the small amount of fluid which is still present next to the retina and cause increasing problems. Endophthalmitis following injections is something which we all dread. The inoculum is right into the vitreous cavity. You can see this is after Ozurdex, which can be a nightmare. Immediate surgery is necessary, removal of Ozurdex is required, and you end up in surgical intervention. So to conclude, intravitreal injection is the primary thing. Surgery is something which you should always be prepared for, and talk to the patient regarding it at the first set, and a case-based approach cannot replace any dictum or any study which could give us some guidelines. Thank you for your.
So thank you, Dr. Parveen, for that insightful series of cases about endophthalmitis. So I think we have time only for one question which we can take for Dr. Parveen if there are any questions from the house. So,
what is the dose of the intravenous antibiotic that you have used for the preterm and the neonates?
So just like we reduce the dose of anti-VEGFs also when we treat these patients, we reduce them by half to 1/3. So that is usually enough that is required. You cannot give the full dose, but half or 1/3 of the drug can be easily given without any increase in intraocular pressure also. That is also you have to take care of.
so I think we'll conclude now, and thank you so much for being